Hello, thank you for joining us. My name is Vani Konda, and I am here with Dennis Yang, and we will be speaking on poem. Dennis, for practicing gastroenterologists, what are your suggestions for someone who suspects that their patient has achalasia? What are important considerations for patient selection when we're thinking about poem?
Thanks, Fanning. I think the important point is that any patient suspected to have achalasia or difficulty swallowing for that matter should undergo a comprehensive diagnostic workup. And that should include clinical history, review of medication, as well as tests. The main take home message is that the diagnosis should not be based on isolated tests, but on the clinical picture as a whole.
And for our advanced endoscopists who perform poem, what do you think are the key takeaways from this clinical practice update for their poem practice and post-procedure protocols?
Yeah, I think POEM now has matured as a technique since its introduction to clinical practice more than a decade ago. And we know that it's equivalent in terms of efficacy. It has at least similar outcomes to Heller myotomy and pneumatic dilation for type 1 and type 2 achalasia, with better results for those with type 3 achalasia. However, besides disease phenotype, we need to remember that choosing the right treatment for the patient is going to be based on multiple factors, including patient characteristics as well as local expertise.
And when someone has a poem and it returns back to their primary gastroenterologist, what are recommendations that you have for that patient's long-term care? And what would prompt a referral back to the person who performed the poem or a esophageal referral center?
Yeah, I think that just like diabetes and hypertension, we need to remember that achalasia is a chronic disease, and long-term post-procedural surveillance is strongly encouraged to monitor disease progression as well as potential complications of reflux. We need to remember that surveillance should be considered irrespective of patient symptoms because many of these patients may remain asymptomatic. And I think primary gastroenterologists should have a very low threshold in referring the patient back to the palm endoscopist or any specialized esophageal center because the etiology of symptoms in these patients can be quite difficult to tease out and often require comprehensive diagnostic workup.
Thank you for sharing these updates with us. And thank you, everyone, for joining us.
Thank you.